Well, today we're going to talk about improving outcomes for cancer survivors. I'll particularly focus on the cardiovascular, cancer-related, and mortality benefits of physical activity during and after cancer treatment. My goal is to convince listeners of the importance of physical activity for everyone, but especially for cancer survivors. To do this, I'll walk you through a body of evidence derived from the medical literature. Some of the presentation slides may appear to be a bit overwhelming at first glance by a layperson, but I'll point out the take-home message that each one illustrates. Much of the research on the effects of exercise and other physical activity has been conducted primarily in breast cancer, with lesser focus on other malignancies. To my knowledge, there is no consensus as to how and when to implement efforts to promote increased physical activity in lung cancer survivors. Lung cancer survival gains have lagged behind those of other types of cancer. However, 35% of lung cancer survivors, more than 5 years from their initial diagnosis, still experience quality of life impairment. In some respects, lung cancer survivors are more likely to have significant limitations compared to survivors of other types of cancer. Lung cancer patients tend to be older and have a smoking history, along with other comorbid conditions such as hypertension, coronary heart disease, and COPD. In fact, COPD is present concomitantly in 73% of male and 53% of female patients with newly diagnosed primary lung cancer. Additionally, surgical resection of tumor and radiation therapy further compromise pulmonary function and functional capacity. Limiting dyspnea, shortness of breath, and fatigue are common in this population. The term dyspnea spiral has been sometimes used to describe the development of shortness of breath leading to activity avoidance, which results in further loss of functional capacity through physical deconditioning and muscle weakness. The American Cancer Society, the American College of Cardiology, the American Heart Association, and the American College of Sports Medicine all recommend 150 minutes of moderate intensity aerobic activity per week, or 75 minutes of vigorous intensity aerobic activity per week, or a combination of these. Weekly muscle strengthening guidelines for adults include at least 2 days of moderate intensity activities that involve all major muscle groups. This would include such things as sit-ups, push-ups, lifting weights, and using resistance bands. Now, our target audience today consists of lung cancer survivors, their families, their friends, and other supporters. I believe that the lessons learned here also could be enlightening to the community of healthcare providers who interact with cancer survivors. By definition, a person is a cancer survivor from the time of initial cancer diagnosis through the balance of their life. This includes those living with cancer, those beginning cancer treatment, and those free of cancer following completion of therapy. Statistical data shows that survivors of all cancers are increasing in number, living longer, and getting older. In 2019, 67% of all U.S. cancer survivors, representing a population of more than 10 million people, had survived at least 5 years following their cancer diagnosis. Over the next decade, we can project that this population of long-term survivors will increase by 1/3 to more than 15 million people. While in 2019, 64% of cancer survivors were age 65 or older, by the year 2040, more than 70% will be senior citizens. This will produce more challenges as the effects of cancer and cancer therapies are superimposed upon the normal effects of aging. Increasing cancer survival rates have led to interest in what happens to cancer patients who have completed their cancer therapy. The majority of exercise intervention research in cancer patients has involved breast cancer survivors and, to a lesser extent, patients who had undergone stem cell transplants for hematologic malignancies. Studies of these patient populations and others have revealed a complex interconnection between cancer and cardiovascular disease. In fact, there is a growing awareness that, although great strides have been achieved in extending cancer survival, the cardiotoxic effects of cancer therapy and accelerated underlying cardiovascular disease may produce a glass ceiling that limits overall survival. So finding ways to break through that glass ceiling is critically important. And when we talk about cancer and cardiovascular disease in the same breath, we often refer to the multiple hit theory. So what is the multiple hit theory and why is it important? Well, cancer survivors suffer multiple injuries to the cardiovascular, pulmonary, and skeletal muscle systems. The normal function of each of these working together results in what we commonly call physical fitness. The cumulative effects of various insults form the basis of the multiple hit theory. Common risk factors for cancer and cardiovascular disease, such as obesity and smoking, for example, result in various comorbidities. There are direct adverse effects of cancer itself. Additionally, cancer therapies may have long-lasting toxic effects. Some toxic effects are more well-known and obvious to patients, such as persistent neuropathies from vincristine or cardiac muscle weakness from doxorubicin. There are also indirect effects of cancer, including poor nutritional status, weight gain, and physical deconditioning. These can affect quality of life as well as health. The consequences of these multiple hits is that cancer survivors living at least 5 years beyond their initial diagnosis have a cardiovascular mortality risk that is 1.5 to 3.5 times higher than their age-matched counterparts with no cancer history. Unfortunately, cancer survivors don't return to their former selves following treatment. They continue to carry scars, both literally and figuratively, from cancer. As a result, they are physiologically older than their chronological age, and that has important consequences for them. Now, before going on to cite specific research study data, let's briefly review the gold standard for quantifying cardiorespiratory fitness. Cardiopulmonary exercise testing is an objective, reproducible method for measuring exercise ability by assessing peak oxygen consumption, which we denote as VO2. Now, you may recall from high school science class that there is aerobic metabolism and anaerobic metabolism. When your oxygen consumption plateaus, then you've hit the wall as anaerobic metabolism begins to predominate. A 2012 study in the Journal of Clinical Oncology described the effect of cancer therapy on cardiorespiratory function. An interesting fact here is that researchers from NASA, the space company, also contributed to this study. NASA scientists have an interest in preventing declines in cardiopulmonary reserve during extended spaceflight by their astronauts. Physical deconditioning typically occurs during prolonged weightlessness. It turns out that their expertise is also applicable to the study of cancer patients. This study demonstrated a significant physiologic aging effect of cancer in cancer therapy. As already mentioned, cardiorespiratory function and reserve, also known as fitness, rely on the interworking of the cardiac, pulmonary, and musculoskeletal systems. In this particular study, 248 women with breast cancer underwent cardiopulmonary exercise testing to determine peak VO2 as the objective measure of their cardiorespiratory fitness. These women were divided into 4 groups. For non-metastatic breast cancer, the groups consisted of the before treatment group, the during treatment group, and the after treatment group. Those women with metastatic breast cancer who received continuous treatment for their cancer comprised the ongoing therapy group. Peak VO2, which corresponds to cardiorespiratory function in these 4 study cohorts, were compared to age and sex-matched predicted values. On average, peak VO2 was 27% less in the breast cancer group than in the age-matched sedentary but otherwise healthy women without a history of breast cancer. The cancer patients had lost more than a quarter of their expected level of fitness. As you can see in the figure, plotting out peak VO2 versus age provides additional perspective. Note that the gold line represents healthy sedentary women. The blue lines represent the statistical average for the breast cancer groups. The mean peak VO2 for a 40-year-old female survivor of breast cancer in this study was about the same as a 70-year-old healthy sedentary woman. Said a different way, a 40-year-old female breast cancer survivor is physiologically speaking like a 70-year-old sedentary woman without a previous diagnosis of breast cancer. That's pretty sobering data, and it has very significant consequences. Now you may think, well, that's just one study, maybe they got it wrong. In fact, that would be wishful thinking. Rather than being just the isolated finding of a single study, this cancer-related physiologic aging seems to be a universal phenomenon. Data suggesting strikingly similar findings were later described for stem cell transplant survivors also. And in another breast cancer study, which combined data from 27 observational studies and clinical trials of breast cancer patients who had exercise testing pre- and post-treatment, mean VO2 max in these patients was compared to a population database of healthy women. As you can see on this slide, the study subjects had a mean age of 52, so they were not very old. They weren't terribly overweight either, as their mean body mass index was 28. Yet, even prior to beginning adjuvant cancer therapy, VO2 max was already 17% lower in the women with breast cancer as compared to healthy sedentary women. This fitness gap widened further after adjuvant cancer therapy. So if you look at the chart that's on the right side of that slide, when researchers divided the data from healthy women into age groups, we see that the cardiorespiratory function of the average 50-year-old breast cancer patient in this study was most like that of a healthy sedentary 60-year-old woman. This cancer-related premature aging process regarding functional capacity has significant effect on outcomes. Functional capacity is an important determinant of an individual's ability to work productively and to hold a job, and to perform activities of daily living independently. Poor functional capacity can result in disability. The significance of these study findings, though, extends beyond functional capacity because we know that peak VO2 is an independent predictor of both cardiovascular and all-cause mortality in a broad range of populations. So what can we do about this? Actually, there's a lot that can be done, and I'll show you. But first, let me explain how we describe physical activity intensity. The use of METs, or metabolic equivalents, allows us to quantify exercise intensity. One MET is the amount of energy that your body uses in each minute while resting quietly. A 2-MET activity, therefore, would expend twice as much energy as compared to rest. A 3-MET activity would expend 3 times that amount of energy, and so on. METs correspond to calories burned. There are free online calculators for determining the number of calories that you would expend during specific activities. For those of you interested, I provided a link on the slide. Also, there are several online sites that provide more general estimation of METs for various types of activity. In this slide, I've shown how brisk walking per guidelines for 150 minutes per week equates to about 9 MET hours per week. We'll refer to that number in the next slide. This group of almost 1,200 adult survivors of childhood Hodgkin lymphoma was followed for 12 years. There was a significant reduction in cardiovascular disease events with exercise. The greatest magnitude of benefit was achieved by about 9 MET hours per week, after which the benefit tended to level off. As shown here, the incidence of cardiovascular events was reduced by half simply by following the standard guidelines for recommended weekly exercise. An Australian review of 100 studies showed that patients who exercised after receiving a cancer diagnosis had fewer cancer-related adverse effects and a lower risk of both cancer recurrence and mortality when compared to patients who either did not exercise or exercised minimally. And the findings are impressive. 28 to 44% reduction in cancer-specific mortality, 21 to 35% reduction in cancer recurrence, 25 to 48% reduction in mortality from any cause. I have no doubt that if exercise were a medication, it would be regarded as a wonder drug. So, why do so few cancer survivors have this information? I believe that the explanation may lie in the fact that the most overlooked solutions are often the simplest. I guess it's human nature. Yet there's another confounding factor, and it's also very human. It's hard to exercise when you have cancer, and it's really hard during active cancer treatment. For some individuals, achieving 150 minutes of moderate aerobic activity each week is just not realistic. But less seems to be okay too, and I'll show you that data. In this 2011 study published in The Lancet, individuals who averaged only 15 minutes of moderate intensity exercise per day still had significant health benefits when compared to individuals who were inactive. This figure shows the relation between daily physical activity and reduction in all-cause mortality compared with individuals in the inactive group. In fact, when compared to individuals in the inactive group, those in the so-called low-volume activity group had an impressive 14% reduction in all-cause mortality. This mortality benefit persisted even after adjusting for age, health status, and cardiovascular disease risk. The bottom line here is that the worst thing to do is to just sit. Over a period of 9 years, researchers followed a group of U.S. cancer survivors prospectively through questionnaires and interviews. Cancer survivors with higher sitting time had increased all-cause, cancer-specific, and non-cancer mortality risks. Less than a third of these cancer survivors were physically active, as defined by leisure time physical activity of at least 150 minutes a week. More than half reported having no leisure time physical activity during the prior week. These researchers found that for each 1 hour increase in daily sitting, there was a 7% increase in all-cause mortality. There was also a 9% increase in cancer mortality and a 5% increase in non-cancer mortality. Fortunately, as you can see in the left half of each of these figures, physical activity seemed to ameliorate the effect of prolonged sitting. For people who have time constraints such that finding opportunities for even 15 minutes of moderate intensity exercise per day is difficult, here's a study published in the December 2022 issue of Nature Medicine that may offer an alternative. Performing 2 or 3 short bursts of vigorous physical activity per day during daily activity in non-exercisers was associated with substantially lower mortality risk. Those who engaged in 1 or 2 minute bursts of vigorous intermittent lifestyle physical activity, roughly 3 times a week, for example, walking quickly to catch a bus or rapidly climbing stairs, showed a significant reduction in the risk of dying from cardiovascular disease, cancer, in any cause, compared with those who did not have vigorous spurts of activity. A median vigorous activity duration of around 4 minutes per day, equivalent to about a half hour of vigorous intensity physical activity per week, corresponded to a reduction in cardiovascular disease mortality by nearly a third. So it seems that a little goes a long way. We can clearly see that physical activity has long-term mortality benefits. However, physical activity also has more immediate benefits for cancer patients. Cancer survivors often suffer from chronic fatigue. In fact, fatigue is the most frequently reported persistent effect of cancer therapy, more than nausea, more than depression, and more than pain. It's present in about 80% of cancer survivors. It doesn't matter whether the cancer treatment consisted of radiation therapy, chemotherapy, or a combination of both. Sadly, many patients suffer persistent fatigue for years beyond their initial cancer diagnosis. While patients may have expectations that their fatigue will improve after completion of treatment, this was not the case in about a third of patients, a significant number of whom reported persistent fatigue on serial follow-up questionnaires 5 and even 10 years after their initial cancer diagnosis. Pooled data from this meta-analysis of 14 randomized controlled study trials involving more than 700 breast cancer patients favored exercise as effective therapy for reducing cancer-related fatigue. In addition to reducing fatigue, some other potential benefits of regular exercise include lessening of depression and anxiety, improving sleep quality, helping to achieve and maintain a good body weight, improving one's overall quality of life, and strengthening the immune system. Parenthetically, this effect on the immune system may be very important in suppressing cancer. Dr. Jessica Scott at Memorial Sloan Kettering Cancer Center led a study which evaluated the optimal timing of exercise intervention when initiating adjuvant chemotherapy in breast cancer patients. She and her collaborators randomized 158 inactive women with breast cancer prior to chemotherapy into 4 groups. In addition to a usual care group, there were 3 exercise intervention groups. One group received exercise intervention 3 days a week concurrent with their chemotherapy. For another group, the exercise intervention began upon completion of chemotherapy. The third group attended the exercise sessions both during chemotherapy and afterwards for a total of 28 to 40 weeks. Subjects underwent cardiopulmonary exercise testing for determination of VO2 at baseline, again immediately after completing chemotherapy, and then 2 to 3 weeks later. At baseline, cardiorespiratory function was below the norm for all patients, which is consistent with multiple other studies of cancer patients, as I've already shown. The usual care group in this study further lost ground with an additional decline in peak VO2. Each of the exercise intervention groups, however, experienced improvement in peak VO2. The VO2 gains were about the same whether exercise intervention occurred during or after chemotherapy. However, the greatest gain was in the group that exercised both during chemotherapy and for the 14 to 20 weeks afterwards. This and other studies have shown that exercise intervention is not only safe, but also beneficial in reducing the decline in cardiorespiratory function that is seen early after cancer diagnosis. Now, I acknowledged earlier that regular exercise or even maintaining a beneficial level of physical activity is hard when you have cancer. Exercise must be individualized, of course, and it would depend upon physical limitations imposed by cancer, cancer surgery, age, and other comorbidities such as arthritis, back problems, and if there were a history of lung resection, reduced lung functional capacity. So there is really no one-size-fits-all approach. Another study that demonstrated an early mitigating effect of exercise intervention in patients who were scheduled to receive chemotherapy for cancer was the ACT trial. One of the interesting things reported in ACT, which included patients with breast, testicular, and colon cancer, was not just the outcome. Rather, it's the reasons given by those who were eligible to participate in the trial, but ultimately declined. This may help us identify potential barriers to participation in a cancer rehab program. So out of a pool of around 500 eligible individuals, 130, or about 25% of that group, declined. The majority gave one of the following reasons. 1, travel distance. 2, time constraints. Or 3, feeling too stressed, essentially being overwhelmed. Similar reasons were given by 23 initial participants who later dropped out of the trial. Appointments for doctor's visits, chemotherapy infusions, radiation therapy, imaging scans, etc., filled the calendar of actively treated cancer patients, consuming both time and energy. Patients are left feeling emotionally drained and physically tired. Psychological inertia sets in. We need to find creative ways to reduce barriers, present helpful information, and provide opportunities regarding physical activity after a cancer diagnosis. Now, more Americans than ever are surviving lung cancer. While lung cancer remains the leading cause of cancer deaths among both men and women, over the last 5 years, the survival rate has increased 21% nationally. New targeted therapies are improving outcomes in lung cancer. Another very important contributing factor is earlier diagnosis. Only 26% of cases are diagnosed at an early stage when the 5-year survival rate is much higher. The Save by the Scan campaign is an effort to promote screening with low-dose lung CT scans for patients at risk. So the disease is identified at an earlier stage when treatments are more curative. So far, only 5.8% of eligible high-risk individuals are being screened. It's estimated that widespread implementation of lung cancer screening with annual low-dose CT scans in high-risk individuals could reduce lung cancer deaths by up to 20%. I must admit that study data regarding physical activity in lung cancer patients is relatively scant. Many of the studies have looked at the effects of exercise intervention in lung cancer, have had only a small number of patient participants with overall inconclusive results. However, keep in mind that as cancer survival increases, other factors besides cancer-related mortality become drivers of overall survival. Although more research is needed, I believe that we should anticipate seeing a mortality benefit from exercise and other physical activity in long-term lung cancer survivors, much like we have found in other cancer survivor populations. I've presented here what I believe to be an under-recognized but vitally important topic for discussion by cancer survivors, their families and friends, and their healthcare providers. We've reviewed ample evidence that whether it means less sitting, more leisure time physical activity, or some formal exercise intervention, a program of increased physical activity provides a huge benefit to cancer survivors. This benefit manifests both early and late, even years later. Quality of life can be better maintained. The risk for late development of cardiovascular disease events and recurrence of cancer can be reduced. Functional disability can be prevented. These benefits not only have enormous impact on the life of individual patients, but they can also ultimately lower society's healthcare cost burden. Additionally, maintaining and improving cardiorespiratory function leads to a significant reduction in all-cause mortality. Thank you very much for your attention.
So we do have some questions in chat, but one thing before I move into the chat, though, that I know when you spoke at the Triad, Dr. Bodek,
yes,
that something that I found particularly interesting was the CT scans that everyone gets.
Yes.
I think you know exactly where I'm headed.
Yeah, I do.
Yeah, would you want to take over since you know
Sure.
this area a lot better than I do?
Well, cancer patients and lung cancer patients in particular often get CT scans of the chest, multiple times in fact. Radiologists in recent years have been advised that they ought to include in their radiographic reports whether or not coronary artery calcification is present. calcification occurs in diseased blood vessels. So when a blood vessel has a cholesterol plaque, atherosclerotic plaque in it, that plaque, the oily component of the plaque, tends to draw in the dissolved calcium in the bloodstream. This has nothing to do with taking calcium supplements or eating yogurt or drinking milk. So there is a normal amount of calcium that circulates in the bloodstream because calcium is very important in a lot of the chemical reactions that occur in the body. But the plaque in the blood vessels is almost like a magnet. It draws these calcium ions into the plaque where it's incorporated, and it forms almost like an eggshell appearance along the wall of the blood vessel. And this is very easily seen on x-rays. It's the reason why bones show up as white. So bones are, mostly calcium and some phosphorus, but the bones show up very well on x-rays. And so this is like a little rim of bone that lines that calcified atherosclerotic plaque in the blood vessel. This is literally the radiographic equivalent of hardening of the arteries. We can go back today, look back at CT scans from several years earlier, and in retrospect, see that there's some calcium in the walls of the blood vessels. But, that wasn't the focus of the test. And the body report focused on the reason why the doctor ordered the test and not necessarily on all these other incidental findings. But as an incidental finding, it's really a very important finding because it identifies people who are at risk. Much like we know that people who have high blood pressure, have diabetes, have high cholesterol, have a strong family history, they're more prone to having a cardiac event, a heart attack, unstable angina, the need for revascularization with bypass surgery. Coronary artery calcification is another way to identify people at risk. They may be completely asymptomatic. The amount of plaque in the wall of the blood vessel may be non-obstructive. So they could have a 10% plaque narrowing that still shows that rim of calcium. They would be completely asymptomatic because the amount of flow that can get past that plaque remains normal even with vigorous activity. So they may not manifest any evidence for ischemic heart disease for many years thereafter. All along, if they had that information, they could have been perhaps modifying their risk factors, getting their blood pressure better controlled, making sure that their cholesterol was as low as it should be, making sure that they didn't develop diabetes because they were overweight and they already had pre-diabetes. Maybe there can be some early intervention to basically arrest the further development of atherosclerosis and hopefully protect people from having a cardiac event down the road. So it is very important for cancer patients to inquire on these CT scans of the chest whether or not there is any evidence for coronary calcification, because it could mean a change in how they approach their cardiovascular risk factor management. And so sometimes it does require a direct question. By the way, when we're talking about my CT scan of the chest, I've heard that sometimes there are these coronary calcifications that can identify someone at risk for future cardiac events. Do I have any evidence of that? That would be a simple question to ask and easy to answer.
I'm going to be a new patient of his in November, and I'm excited about it. But when I had my CT scan, it was through the abdomen, which that was ordered through my great team at Novant. And that's where they saw the hardening of the arteries, if you will, in the abdomen and part of my heart. Well, that directed me towards the cardiologist, which thankfully it did. But I had no signs. Like you said, I had no signs, I had no symptoms. There's a medical history, but I was feeling fine. I was great. I had no idea. And when you're going through the whole chemo and I'm going through the whole brain tumor stuff and all that, but there's so much other stuff going on. But it would have been easy to miss, but my team is so phenomenal. They didn't miss a heartbeat. They were like, no, you need to go to cardiology.
No pun intended.
No, they were amazing. Novant is just amazing. My team is so awesome. And I can't wait to see you in November.
Thank you. And you make a good point, actually, because atherosclerosis is not only a disease of heart arteries, but it's a disease of arteries in general. It could be arteries in the neck, it could be arteries in the brain, it could be arteries in your abdomen or in the legs. And so vascular calcifications, wherever they are, that does identify you as someone who has atherosclerosis, and that puts you at a higher risk for these cardiovascular events. On kind of the same topic is that, receiving a cancer diagnosis and undergoing cancer therapy, it's kind of an all-consuming thing, right?
Yeah, I just had my 33rd treatment.
Yeah. So a lot of times people don't follow up as closely as perhaps they should be with their primary care doctor or their endocrinologist. And so people who do have things like diabetes, maybe their blood sugar control becomes not as good as it was. Maybe their hypertension is not really as well controlled as it was. Because that's not what the focus is.
There's so much going on.
You're focused on the cancer diagnosis and getting through that therapy, and all the other things kind of get pushed to the side. But my experience with oncologists is that they are very good internists because of managing cancer survivors is, it's not just one thing. You have to kind of take care of the whole person. And so I have a lot of respect for my oncology colleagues and their skills. But even so, again, getting back to, how much time you have, sometimes you can't shoehorn all things into that office visit.
Look, they spend an hour 20 minutes with me. I have never had a complaint. My team is just phenomenal.
Great.
I'm so fortunate. I'm so blessed.
Yeah, thank you.
I have a question for you, Doctor.
Yes.
So you were mentioning VO2. Sorry, my camera isn't working. I don't know.
That's okay.
Anyway, VO2 max. I have an iPhone.
Yes.
And the Cardio Fitness has it on there, but honestly, I've never known what it meant. Or
okay. Now you do.
Range. It's like 35, and I'm like, okay,
right.
That's
right.
Nice. How do I find out? Is that a good number? I don't even know if that's a good number or whatever.
Well, it says what? It estimates that yours is 35.
35.
Yeah, that's good.
Well, how do you know?
I'll tell you. One definition.
You were showing those charts, and I'm like.
Yeah,
okay.
There is criteria for disability based on VO2. So most people who have a VO2 of 18 or less would be considered disabled. They would have difficulty taking care of themselves, doing all the things they need to do. So 18 is a cutoff below which people are generally disabled, and so you want to. You want to avoid getting down to that level. And I will tell you that, as I pointed out in numerous studies, there's something about cancer, that you're kind of behind the eight ball right from the get-go as far as your cardiorespiratory function. You're starting at a lower level than, as I said, somebody else your same age, statistically, you're identical twin who doesn't have cancer. And when you go through cancer therapy, that already lowered cardiorespiratory fitness level reduces further. And it won't come up unless you try to do something to raise it. It's the same thing when people are sick in the hospital for extended lengths of time. You don't have to lay in bed in the hospital, maybe just overnight or a weekend. You come home, it takes you a week to recover for every day you spend in the hospital. Because that's how quickly you lose your cardiorespiratory function, and a lot of people, they wait and wait. When am I going to start to feel better? And it's hard. You have to do a little. We all understand that. These recommendations that everybody puts out for the general population, the 150 to 300. Minutes of moderate aerobic activity per week, that's a guideline. That's something to strive for. But, for people who have limitations, people who require oxygen, as many lung cancer survivors do, they're not going to be running on a treadmill. They're not going to be, doing stair steppers and doing all this sort of thing. But again, as I've shown, even doing little bits, just as long as you're getting up out of a chair and moving, it has just a tremendous amount of benefit. I mean, it's amazing. And it's a shame that people aren't told that they just need to get up and do a little bit. Maybe some days you don't feel like you can do it. I get up early in the morning. I turn on the television as I drink my first cup of coffee of the day. And sometimes flipping through, I go by the public television channel. And early in the morning, pre-dawn hours, there's been something on for decades called Sit and Be Fit. And I give a plug to this all the time. You don't have to get up at 5 o'clock in the morning like I do to see it, because it is actually free on YouTube. And, if you have a computer, you can just go on, Google it, Sit and Be Fit, and go on YouTube. And they have a whole bunch of episodes. This nurse who's been doing this has been doing this for, I think, over a decade. And so there's a lot of episodes. And so a lot of her stuff is just sitting in a chair and doing resistance bands. And, that's a good way to get started. I also talk about yoga. I know some of the other cancer groups, they do have yoga programs. So sometimes for people who are very physically deconditioned after treatment, yoga sometimes is a way to kind of, be an intermediary sort of thing before doing something more vigorous. So we're not talking about hot yoga. we're talking about simple yoga, but just, getting up, stretching, that sort of thing, any little bit.
Yeah, I do elliptical a couple times a week, and I do walking a couple times a week. But last week, I have shortness of breath, probably like a lot of people on the call here. And last week, I kind of got concerned because I went with a group for a hike up a mountain, and I went, it was 1.5 miles up a mountain, just a face, straight up. And I did the first mile or so, and then I was just like, you guys go do the last half mile on your own. Yeah. But
it sounds like you're quite active, so good for you. And that's probably why you're.
Well, I wish I could have done that last half mile, but I was like, okay, this is like,
Right.
Anyway, all right. Thanks, Doctor. Appreciate it.
Sure.
And we do have some questions in chat. Can exercise improve lung functions?
Yes, in a way. I didn't talk about pulmonary rehab, but pulmonary rehab was developed to try to improve lung function and functionality in patients with severe chronic lung disease. A lot of the studies have used something called a 6-minute walk test. And so 6-minute walk test is how far you can walk in distance, in meters, in 6 minutes. And that is a measure of functional ability. Higher, better prognosis overall. In patients who have lung cancer, and the primary treatment would be resection, sometimes the lung function is not good enough for them to be a safe surgical candidate. They would be deemed inoperable. So there is a role for pulmonary rehab in such a patient. Sometimes going through pulmonary rehab can improve the patient's function such that they become operable. Now, they're not going to be, the greatest candidate, but they will no longer be inoperable. So yes, it does have effect on lung function.
Another question, wanting to know about fatigue and immunotherapy.
Mm-hmm. It happens.
I was feeling fine, like after chemo, but then I've been on immunotherapy for like 3.5 years. And the fatigue is just, I'm like, what's going on here? So does immunotherapy, I'm obviously believe that immunotherapy does affect the cardiovascular system as well as chemo.
Mm-hmm.
That was my question.
Yes. Yeah, I would agree with that. And yes, it is, fatigue is associated with immunotherapy. But, be sure that you're, and I'm sure your doctor is looking after all these things, but, there are other things that can cause fatigue, and those things need to be ruled out. So anemia can cause fatigue. Lack of proper rest. So, sometimes people are poor sleepers at night for various reasons. They may be cancer or not cancer related. So those sorts of things can contribute to fatigue. An underactive thyroid can contribute to fatigue. Sometimes, by the way, immunotherapy can affect the thyroid function. So, that's a way where immunotherapy could, in a more roundabout way, cause fatigue. But, a lot of times as people get older, hypothyroidism or underactive thyroid is kind of an indolent sort of thing, and it can sneak up on somebody, and they may initially just attribute it to getting older. Well, yeah, they're getting older, but, their thyroid gland is getting tired, and it's not putting out the normal amount of thyroid hormone that is necessary. So that's a simple blood test. And, a lot of times particularly in older patients, that becomes a routine part of the annual blood work, or if there's any other reason for checking it more often than that. So yes, fatigue with immunotherapy, but it can also be due to other things that need to be excluded.
Thank you so much.
Sure.
Hi, I'm 69 years old. I've had a left pneumonectomy 6.5 years ago. I had chemotherapy then, and I had a recurrence and had more chemotherapy and immunotherapy. In between that break period, as the doctor called it, I was back to being able to walk a couple of miles with my dogs. This last time, the immunotherapy, I know someone said Keytruda is great. Well, it was killing me.
Yeah.
They had to take me off of it. I'm only now back to walking. I walk a half hour every day. I can only get in a half a mile in that half hour.
Mm-hmm.
I do clean my own house. I do cook and, take care of all of that. My heart, when you said the CT scans, I had noticed they do check that. Mm-hmm. That all seems to be fine. Is this, for my situation, an acceptable?
I mentioned in my talk that there's no one size fits all
right.
With regard to this. Everybody's different. Everybody has different abilities. And so I would say, do what you can do.
It's been disturbing me that I can't get back to what I was doing.
Well, sometimes you could also, instead of trying, if a half hour is all you can do at a time and you like to do more, then, divide it a little bit. You could go out walking more than once. You could, let's say you're going a half an hour. So maybe if you have the ability, you can go out twice, maybe, 15 or 20 minutes twice a day, weather permitting, instead of that 130-minute all at once.
Yeah, the weather permitting has been an issue.
Yeah, you have to go either early or late.
Can't
right.
breathe.
Right. But the other thing is, and I thought maybe Lynn was going to ask me about this because this was a topic when I talked to the group a year ago. The thing about step counters. Remember, Lynn? Step counters.
I used to have one.
Yeah.
Of them,
yeah. And, the 10,000 steps thing. I think that that could be helpful for people. And, if you have a smartphone, a lot of them already have built-in fitness apps there that you can activate to do a step counter. That sometimes acts as a prompt. So you could look at it from day to day. Today I did 4,000 steps, maybe tomorrow I'm going to try to do a few more. And then you could use that as kind of a guide, because from day to day, it's kind of hard. If you're really not able to increase your level of activity by big leaps and bounds, maybe you could use the step counter to allow you to kind of more gradually increase your activity.
Yeah. Some of the other surgeries I've had, related to other cancers,
Yeah.
have limited, like I'm not allowed to, oh yes, I take out the garbage can and stuff, but I am not allowed to do lifting, like heavy lifting or, certain things.
Mm-hmm.
I've got to make sure I squat, do not bend over. I can't lay flat.
Yeah, so you have some
otherwise
limitations.
I can't. Yeah. And I'm definitely not overweight. I'm supposed to gain weight, which always makes me think every time I walk, how many calories am I burning?
Right.
But okay, thank you. So I guess
it's individualized.
I'm doing what I'm supposed to.
Yeah. And it sounds like you are making the effort. There are plenty of people that don't make an effort at all. Those are we talked about the people that had no leisure time activity in the previous week, that are people that are inactive. So you certainly don't fit that category. You are getting out. You're walking a half hour. You're doing your housework. So those things are very important.
Okay, the last question. If I feel like I ran a marathon because I speed up my walking, is that dangerous?
No.
Okay, because I was like, I come back, I sit down like.
I would say do what you can do. Now, when you feel like you have had enough and you have to stop and take a little rest, then you should do that. That's your body telling you you need to catch up. I talked on that one slide about hitting the wall. Marathon runners hit the wall. And that's when you kind of crest that hill, and now your oxygen consumption is not able to keep up with your demand for activity, and so you start to have this anaerobic metabolism. That's when you start to feel like you're hitting the wall. That's when you need to take a rest. Because that's what I take. Yeah, it's probably not to your benefit to continue to push yourself after that point.
Right, because when I played sports, we always kept pushing. So
yeah, well, this is not training for the Olympics. It's not. So this this is for good health.
Okay, thank you.
You're welcome.
Briefly, I'm stage 4 EGFR, diagnosed in July 2019. I had a heart attack in December of 2020, I believe it was. And of course, being on Tagresso, I wanted the cardiologist, this was my first time ever having an event, to look at whether or not it was the Tagresso. But I do have a family history of heart disease. And so he monitored me for probably about, 2 years after that. He ruled out the Tagresso, put a stent in because they did find a 95% blockage. And so after about, say, 2 years of seeing him every, 3 to 6 months, you're doing okay. Continue to take your medicine. Call me if you need me. So with listening to you, with the importance of maybe having oncologist, cardiologist, how often or should I, contact my regular cardiologist just for monitoring? Because right now I'm not going to him anymore because I haven't had any more events that I know of. But then I didn't know I had that heart attack either. It was like 3 days later before I got to the hospital because it didn't debilitate me,
Right. Well, you clearly have coronary artery disease if you needed a stent in your coronary artery. So you're someone who, I think should be seen by their cardiologist at least annually, and perhaps even every 6 months. For you, it's important to keep your blood pressure under control. Sometimes the medicines that you take for management of your cancer can raise blood pressure. And changes in that medicine can alter how high your blood pressure is. And so it would be important for somebody to manage your hypertension well.
When I call them back then to get back on his schedule, I call them to tell them I want to be seen because or why.
For follow-up, because you have a history of coronary artery disease. And you had a stent. And, you have, as you said, you haven't been seen for a couple of years, and, it seems like it's time for you to be seen again.
Thank you, Dr. Bodek. I
You're
appreciate
welcome.
that. I've
Sure.
enjoyed this.
Okay, good.
I had a question. I have a history of ARVD,
Mm-hmm.
and I was just wondering, it's important to follow up with a cardiologist, not necessarily an oncologist, cardiologist.
Right.
Is that correct?
That's right. To be honest with you, there aren't too many cardio-oncologists around. It's a relatively new specialty. I only became interested in cardio-oncology in 2019. And it was at that point that, the American College of Cardiology began to have seminars on that topic.
Right.
But there, even today, as far as cardiology training programs, there aren't really a whole lot that produce cardio-oncologists these days.
Right.
So a lot of us who are currently cardio-oncologists, we didn't start out as cardio-oncologists. We kind of, trained ourselves, and we kind of evolved as the specialty kind of sprouted.
Okay. Yeah, I was diagnosed in 2015 with stage 1. And then I had a freak spontaneous carotid artery dissection.
Mm-hmm.
And then being worked up, they found out I have, the genetic testing hasn't come back, but the diagnostic conditions of AR, B, D, or C. So yeah, it came out of nowhere. So I don't know if it has anything to do with the cancer, or it just, I'm lucky to, get both of them.
Sometimes that happens. I have another talk where I discuss how there may be some common genetics between cardiovascular disease and cancer, actually, where those genes can reside in the same family, and some members may get cardiovascular disease, other members may get cancer. So there is a potential link. Yeah, actually, it's something called CHIPS. CHIPS. It's an acronym, but if you Google CHIPS, capital letters, CHIPS, CHIP, and cancer and heart failure in particular, that's where it was initially identified. But you can get some information about that. It's probably not for the average patient to review. It's all kind of highly scientific kind of things, but and mouse models and that kind of stuff. But there does seem to be a link.
Because of I had to kind of tone down what kind of activity. So basically, I always say I just walk now because they're telling me I shouldn't be doing anything. I used to do string classes all the time, but they're telling me not to do that. So, and Sloan Kettering, I have to say, every time I go, they're always asking me, "Are you walking? Are you getting up? Are you moving around?" They're always asking.
I think they're with the program with that exercise because the one doctor that I mentioned, I did actually hear her speak at Sloan Kettering earlier this year, and so they do have a whole staff that deal with exercise physiology in cancer patients.
And I was just going to say, they have a whole program that anyone from any place can join, and they have exercise programs via Zoom. So if anyone's on the call now, if you go to Sloan Kettering, they do have Zoom classes. I can't remember what integrative medicine, I think, is the umbrella it falls under.
One more question, Dr. Bodek. When I exercise, my O2 goes down, my O2 sat goes down into the 70s.
Yeah. Is she wearing oxygen? Is she wearing oxygen? Yeah, she would need to wear oxygen.
Okay. So is it probably it's safe only if she uses her oxygen?
Yeah. Yeah. Okay. So she may not need oxygen at rest, but it sounds like she needs oxygen with physical activity.
Gotcha.
Yeah.
Okay.
I had a quick question. He talked about direct injury. I've had 2 lobectomies. I've had radiation therapy that caused pneumonitis and severe scarring. That my last pulmonary function test was only 45%. So I'm not functioning, on a full deck there, basically. And I get short of breath real easy, 150, 200 feet max. I carry on the SAT monitor. So if I go below 90, I just stop. recover and then keep going. Is that something you're talking about? Just doing short spurts for people that have that?
Right. But if, again, as we talked about a previous patient, talk to your pulmonologist. If your oxygen saturation is dropping below 90, 89, 90% when you're exercising, when you're, or even if you're trying to do your normal activities, go grocery shopping or whatever, you may need to have oxygen during those activities.
Well, I had oxygen when I first started immunotherapy, and I was on 4 liters oxygen. I couldn't walk 50 feet. But the immunotherapy shrunk all the tumors, and I'm proud that I weaned myself off oxygen. So I'm trying not to go back on it. And it's been 2 years. So I can just gradually do what I can with it.
But as you said, you do have less lung function because you've had resections and you've had radiation. Radiation also damages lung tissue. So even in people who haven't had lung resections, if they get radiation that is directed to the lung, either intentionally or as part of breast cancer treatment or Hodgkin lymphoma treatment, that can affect your lung function also. So you may not be able to exercise yourself to a higher oxygen level when you exercise. You may have to rely on some supplemental oxygen in order to extend your activity tolerance.
Because I was just at the pulmonologist. That's who the oncologist refers me to with the shortness of breath. Did
they do a walk test with an O2 sat to test your oxygen level?
No, they just did. I've done that in the past, but I don't know if I could do 6 minutes now. So
I have a quick question. Hello, doctor, and thank you for the information. So I messaged my oncologist, who I saw this past Monday, about cardiac calcification, and he wrote back that the CT did identify some vascular calcification. However, this does not predict short-term risk for a cardiac event. Is there a difference in vascular calcification and cardiac calcification?
Only in which vessels are involved. So coronary artery calcifications are calcifications in the heart arteries. So those are seen on chest CTs. Now, people who have abdominal CT scans or abdominal pelvic CT scans, that may show calcification in the aorta, the abdominal aorta, or in the iliac vessels, which supply the legs. So those are kind of down in your pelvis area. And so that is a marker also of atherosclerotic disease. It's just a different set of arteries. But it does identify a patient who has atherosclerosis. And so, atherosclerosis can affect the arteries to the brain, the arteries to the heart, or the arteries in the abdomen and extremities. Some people have atherosclerosis involving all locations. For some people, it may be limited to the neck arteries, and they may be predisposed to a stroke, or to the heart arteries, and they may be predisposed to a heart attack. Or some people just have vascular claudication. Their legs hurt when they walk a certain distance because there's poor blood circulation to the legs. So it's still the same disease, atherosclerosis, when you boil it down, but it affects people differently depending upon which arteries are involved. What your oncologist said was accurate. It's not a marker of short-term risk. It's a marker of long-term risk.
Okay. Just very quickly then, I've been having trouble I'm a 5-year survivor so far with small cells. So, I love my oncologist. But before that, I started having debilitating cramps in my feet. And my primary at that time, it started about 8 years ago, sent me to a neurologist who could find nothing. Is it possible that vascular calcification can cause those cramps? And that's my last question.
Well, yes. So cramps in muscles in the leg muscles can be the result of blockage. So that would be vascular claudication. So, so when it's almost like angina of the heart, so if you have blocked coronary arteries and you exert yourself, if you exert yourself to a certain degree, someone with blockage may then get chest pain. Well, in people who have peripheral artery disease of the legs, if they walk a certain distance, they may get cramps in the muscles supplied by those blocked arteries. That's called vascular claudication. Now, there's also neurogenic claudication, which can be the result of compression of the lower spine or one of the nerve roots that comes out of the lower spine to supply the legs. So sometimes you have to do an ultrasound study or or at least a blood pressure screening test of the lower legs in order to assess whether the circulation is good or not. The other thing is that, various cancer treatments as a adverse effect can cause neuropathies, and neuropathies can cause pain in extremities also. So you have to kind of try to differentiate all those different things from one another.
Thank you, sir.
Sure.
One last question for you, Dr. Bodek, and that is, at what point would our members want to seek out a cardio-oncologist rather than just a regular cardiologist? Or if you have a choice between the two, do they opt for the cardio-oncologist?
Yeah. I mean, I think in most cases that would be a discussion between the patient and their oncologist or primary care doctor. Because, if there's no particular reason to see the cardiologist or cardio-oncologist, then you save yourself a visit. But again, sometimes in the heat of the battle with the cancer, things are not brought up spontaneously. And so I think it's important for the patient who has concerns that maybe there's something going on with the cardiovascular system to raise that as a topic at an office visit. And together with the oncologist, discuss whether it's reasonable to get some further evaluation by a cardiologist or a cardio-oncologist. It doesn't necessarily have to be a cardio-oncologist.
Okay. But if I had a choice between, if they said either a cardiologist or a cardio-oncologist, do I choose the cardio-oncologist?
I guess since I'm a cardio-oncologist, I would say yes. But there are many more cardiologists as opposed to cardio-oncologists. The primary mission of a cardio-oncologist is this: in the early period of cancer survivorship, following diagnosis and getting started on cancer therapy, the role of the cardio-oncologist is to try to minimize future cardiovascular problems, complications, whether they're treatment related or either because patients already have pre-existing cardiovascular disease that needs to be tuned up so they can better tolerate their cancer therapy. So that's kind of one aspect of what a cardio-oncologist does. And so, it's important to just have kind of an accounting of what one's cardiovascular risk factors are. And that's important general medicine stuff. So, that can be discussed with the oncologist, but also with the primary care physician too. The other thing is that sometimes cancer therapies can have toxic effects on the heart. And sometimes we have to try to adjust the cancer therapy. Sometimes we have to add cardiac medications to try to help the heart. Our primary goal is to allow the patient to receive the best cancer therapy that they can receive and not have the cancer therapy stopped or reduced or changed to something less effective because of some effect on the heart that maybe we can work around if we address some of the heart issues. So that's a very important component. And then the third component is kind of the lifetime long-term survivorship stuff. So I talked about childhood cancer survivors. That group of patients, Hodgkin's lymphoma, most cases very curable. And those people live well into adulthood. But if you look at a group of childhood Hodgkin and young adult Hodgkin lymphoma survivors and their healthy siblings, and you compare the two, the group that are the cancer survivors have a much higher incidence of hypertension. They have, much higher incidence of all kinds of cardiovascular problems. And it's, unfortunately, it's the the earlier toxic effects of their cancer therapy that predisposed them to those future problems. And so, identifying people who may be at risk down the road, even way down the road, is important. And, years down the road, if you've been cured of Hodgkin's lymphoma and you're 20 years out from your treatment, you've kind of relegated that to the attic. You've packed up that box, you put it away in the attic, and you're not really thinking about that. And neither is your primary care doctor necessarily. So sometimes kind of just going over that history, if you're going to see the primary care doctor and you're a long-term cancer survivor, just remind them, I did have cancer at one time, and I was treated for it. Does that have any impact on me today? Is there something that we ought to be screening me for now, all these years later?
Wonderful. Good tip. Thank you. Thank you. And I just can't let you go without asking you this last question. I'm sorry. How do you do the blood pressure on your leg? We do have in our office, we do have cuffs for the ankles. And so with Doppler, we don't use a stethoscope to take the blood pressure. We have a little ultrasound probe that, makes that whoosh whoosh sound, and we can hear it with a microphone. And we can determine the blood pressure in the ankles and compare them to the blood pressure in the arm. And there's a index that we follow. And if the blood pressure, because ordinarily the blood pressure, believe it or not, in your legs is higher than in your arm. That's because of the weight of your blood that causes increased pressure in your lower extremities. And it wouldn't be unusual for your blood pressure in the lower extremities to be 30 points higher than in your arm. If the blood pressure in your lower legs is the same as in your arm or less, that could very well mean that you have a blockage. And so comparing just a simple screening test is called ankle brachial index, or ABI. It's a simple, quick, non-invasive test. It can be done in our office, and that can be a screening test to determine whether people have obstructive peripheral vascular disease.